We're going to talk a little bit about the reports. PAPs will be provided tools to help measure and improve patient care. One of the most important tools is the provider reports. These reports are key to keeping up with your performance relative to each episode and show your eligibility for gain risk sharing. The reports provide performance information for PAPS episodes, such as an overview of quality across a PAPS episode, overview of cost effectiveness, in other words, how a PAP is doing relative to cost thresholds and relative to other providers, and an overview of utilization and drivers of a PAP's average episode of cost. PAP performance reports have summary results and detailed analysis of episode cost, quality, and utilization. A guide to reading your reports is available online and, of course, at this event, which is being recorded. It is valuable to both PAPs and non-PAPs to understand the reports. Reports are issued quarterly starting July 2012. The July report is informational only, and gain risk-sharing results reflect claim data from January through December of 2011. The report issued in October is also informational only and reflects claim data from July 2011 through June 2012. Reports are available online via the provider portal. Now let's look at the reports. The first page will give you the date of the report and the date range of the data included in the report. Please note the disclaimer at the bottom of the page, which states the information contained in these reports is intended solely for use in the administration of the Medicaid program. The data in the reports is neither intended nor suitable for other uses, including the selection of a health care provider. Then it gives you our website for additional information. The next page we want to look at is the table of contents, which will show at a glance all the episodes in which you are considered a PAP in the Arkansas Payment Improvement Initiative. Could be that you only have one or two in the table of contents. This one lists all of them. The report summary. The report summary includes a summary of your performance for all episodes for which you qualified as a PAP. Each episode will show you at a glance your performance in quality, average episode cost, and whether you are eligible for gain risk sharing. The report is color-coded for easy viewing. The green is a gain share. If you will look in the non-specific URI, you'll see the green, there is a gain share of $18. If the quality of services is above the minimum standard and the costs are lower than the commendable threshold indicated with a check mark, you are eligible for gain sharing. The dollar amount will be shown in the third section of the episode in the rectangular box. Gray is no impact on payment. If your costs are between commendable and acceptable, there are no gain or risk sharing. Red is risk sharing. If your costs are higher than the acceptable level, which is in the sinusitis episode, if your costs are higher than the acceptable threshold, regardless of whether the quality standard is met, you are subject to risk sharing. The dollar amount will be shown on the third section of the episode in the rectangular box. This report is for pharyngitis. This summary report has a lot of information on it, so we're going to go over it each section. The first section is the overview. This section shows you the total number of episodes. In this example, there were 208. The total number of episodes included in the report is 142, and the number of episodes excluded is 62. The next section is the cost of care compared to other providers. Range from commendable in green, acceptable in gray, and not acceptable in red. Where you fall in this range is indicated by the dark blue diamond, and all other providers is indicated by the light blue triangle. As you can see from this example, the provider fell in the acceptable range. Also next to this section, you will see the gain risk share associated with this episode of care, which is 0 as they fall within the acceptable range. The quality summary. The quality metrics for pharyngitis are taken from paid claims, so you don't have to enter anything in the provider portal. To be eligible for gain sharing in the pharyngitis episode, you have to have administered a strep test in at least 47% of the beneficiaries for which you prescribed an antibiotic. If you do not meet in this quality metrics, you are not eligible for gain sharing, even if cost is in the commendable threshold. As you can see from this example, the provider met the quality metrics with 78%. It's in the dark blue. The second section shows you the quality metrics that we're tracking, but they are not linked to gain sharing. The cost summary section, the first thing you will notice in this section is the check mark in gray indicating your costs are acceptable. The first bar graph shows total cost for all included episodes compared to total cost for all included episodes after risk adjustments have been made. The second bar graph shows your average episode cost compared to all other providers. Again, your costs are shown in the dark blue and all other providers in the lighter blue. The third graph shows the episode cost distribution from green acceptable to red non-acceptable. As you can see from this example, there were some episodes that were in the acceptable range as well as some in the non-acceptable range. Remember, we are looking at the average episode cost. The last graph in this section will give you the distribution of all providers' average episode cost, again ranging from acceptable to not acceptable. The provider is the blue line in the graph, so you can see where you fall with other providers. This information may be helpful to you in trying to understand the source of high cost and identify the practices that led to lower cost episodes. The last section is the key utilization metrics. There are two graphs in this section. One shows the average number of visits per episode, and the other one shows the percentage of episodes with antibiotics. You as the provider, again, are shown in dark blue, and all other providers are shown in the light blue. This may help you see where improvements could be made. It may also encourage you to identify other providers to see how they may have achieved better results. There is an additional graph of these key metrics on the next page of the report. The next section is the cost detail. This page provides a detailed look at your cost and the average cost of all other providers. Care categories list all categories of service that make up an episode. So you see you've got outpatient, professional, pharmacy, anything that makes up the pharyngitis episode. The number of episodes at the top of the page refers to how many episodes included cost in this category. Average cost per category is shown per PAP and overall. Again, the PAP is shown in dark blue and all other providers in the lighter blue. And again, this detail is important and it may help you to understand where the source of high costs are. The next two reports for not...
Can I just add something here?
Sure.
Because in my presentation, I did not go into some of the core aspects of each of these episodes. So when you look at this, clearly, just to give you some facts on the pharyngitis, something like 60% on the Medicaid data of adults are getting antibiotics for a sore throat. And the prevalence of group B strep, which is the only reason you would give antibiotics for the sore throat, is only 15%. So statewide, we are giving 4 times the rate of antibiotics than there is prevalence of the disease. So you can see the opportunities here for reducing the use of antibiotics, which is a good public health intervention, let alone a whole issue about cost, because most of these pharyngitis episodes are viral, and really the intervention is not indicated for most of the adults you see in the practice. And for children, by the way, it's about 50%, and the case rate is about 25% pharyngitis. The antibiotics really do not improve the speed of healing. All it does is prevent the complications of rheumatic fever. Right.
Okay. The next few slides, there are separate reports for nonspecific URI. You'll notice on this report there's no quality metrics linked to gain share. You're seeing some of the same cost metrics that you saw in the previous report. You'll also see the cost breakdown for the nonspecific URI.
And again, to follow up on this, about 50% of patients with nonspecific URI, which is almost 100% viral, are getting antibiotics. Some of them are getting expensive cephalosporins, so the need for blood counts, chest x-rays, antibiotics here is very, very modest. Now, granted, there will be some patients you're not sure what's going on, may need an x-ray. Most of the experts we talked to in designing the episode said maybe 10%, 15%. We've excluded very small children, infants where there is confusion. We've excluded kids with complex diseases like cystic fibrosis. So for the straightforward child, straightforward adult with a URI, there really is no need for antibiotics and very, very tiny amounts of testing, if any at all.
And the last report is for the sinusitis. Again, there are no quality metrics linked to gain share, but we are tracking some of the quality metrics, and you will see the same breakdown as we had on the previous.
And we have now a number of national guidelines for acute sinusitis. Virtually none of them say that you should treat symptoms of sinusitis in the first 5 to 7 days. Only persistent facial pain, persistent discomfort should be treated with an antibiotic. Most folks will do better with a decongestant and symptomatic care, but only for those with persistent disease should you be getting antibiotics. Sinus x-rays, believe it or not, have no clinical utility even for chronic disease. Those are the kind of folks that might need either an endoscopy or a CT scan, but routine sinus films have no clinical utility these days in the treatment of acute or chronic sinusitis, but particularly acute disease.
Following this page will be a glossary of terms, and then if you go past the glossary of terms, you will see the detailed information for each patient included in your results. Those excluded will not be shown. The detail is broken down by each of the 3 episodes, and this may help you understand what occurred for an individual patient's episode of care.
And to also, we know that many people are concerned about patient demand. We're working with AFMC to reinvigorate our Save the Antibiotic campaign, but we also believe that if all physicians and ER doctors are incentivized to the same message, everybody's at risk, that we can reduce these percentages. It's good public health. It's good economic health. It's really a way of redesigning or being good stewards of, A, antibiotics, and B, health system resources. Now, bear in mind that this is, in some ways, training wheels for the medical home coming up. We would say that going forward, there will be fewer episodes like this for primary care. On the other hand, primary care medical homes will be accountable for total cost of care for their practices and their panels. So decision-making and practice style, patient education like this will be part and parcel of an effective medical home. So we are hoping that this experience will get you prepared for future total cost of care management in a medical home environment where effective primary care physicians may be potentially able to increase their clinical revenue 20-40% by being effective care managers and cost managers compared to their peers.